Hello, everyone, and welcome to the Arthritis Action Podcast. I'm Mark, as always, your host, and this time around, I'm joined by Professor David Hunter. David is a rheumatologist, clinician researcher whose primary research focus is in clinical and translational research in osteoarthritis. He's ranked as the leading expert in the world on osteoarthritis on expertscape.com, the editor-in-chief of Osteoarthritis and Cartilage, and has over 600 publications in peer-reviewed journals. And on top of all that, is the co-director of Sydney Musculoskeletal Health and leads the osteoarthritis team at the Colling Institute. Thank you very much for joining us today, David.
My pleasure, Mark. It's great to be here.
Thank you. It's quite the resume there. I had to actually leave a lot of stuff off because we've only got half an hour or so, and I think I probably could have filled it just reading your qualifications.
Well, I'd much prefer to have a conversation with you than talking about myself.
Perfect. Well, let's do that then. So today's topic is osteoarthritis. So, I mean, as a lot of you probably know, it's the most common type of arthritis, and likely a lot of people listening to this have it. But there's always someone new to it. This is always someone's first podcast, as they say. So we'd like to make this kind of as applicable for as many people as possible. So nice, quite broad look at the condition and all the nuances therein. So despite you not wanting to talk about yourself, my first question is, can you tell us a little bit about yourself and your experience with arthritis?
Sure. So I'm what's called a rheumatologist. So essentially it's a specialist doctor who focuses on people that have bone, joint, and muscle diseases. And I guess the most common thing that most rheumatologists tend to focus on is arthritis. And typically they'll focus on inflammatory types of arthritis, so rheumatoid arthritis, lupus, scleroderma, vasculitis, and so on. I'm one of the rare rheumatologists that tends to have a focus on the most common arthritis, which is osteoarthritis, which is an arthritis that affects about 90% of the people that have this disease. And so I've been a rheumatologist now for the better part of 25 years. And during that time, have spent most of my clinical work, so that's seeing patients as well as doing research and teaching on the disease of osteoarthritis.
Excellent. So you're definitely the man for the job today then.
I'll do my best.
I've no doubt. Cool. So we'll start off, as I said, we're going to keep it quite broad. So let's start off really basic. So what is osteoarthritis?
Yes, so Mark has mentioned osteoarthritis is the most common type of arthritis. Typically, for people that have it, it can affect any joint within the body, but the most common joints that get affected are the knees, hips, and or hands. At least from the viewpoint of the changes that go on at the joint level, this relates to damage to the joint tissues and failure of their ability to innately repair. So every joint has the capacity for repair, and in the context of osteoarthritis, the breakdown processes cause that joint to be damaged. And so that's the disease of osteoarthritis. But I think most importantly for people who have the disease, it's really the illness that's most important for them. So that's the pain, that's the functional limitation, that's the person who lives with disability coming from the joint. And so the reason for distinguishing between the disease, so that's the tissue change, versus the illness, which is the lived experience, is oftentimes the changes that occur at the local tissue level don't often agree with what a person experiences. And so at least for me as a clinician, as for me as a researcher, and for someone like myself who actually lives with osteoarthritis as well, it's much more important what we feel than what it looks like on an X-ray or an MRI. And so what I generally tell people is, focus on your symptoms, focus on what you can do for your symptoms. Don't focus on what you see on an X-ray or an MRI. Osteoarthritis, as I mentioned, is incredibly common. It affects about 600 million people around the world. It's the leading cause of musculoskeletal disability along with low back pain, and is a major cause of unemployment and underemployment because of the virtue of affecting a lot of young people, which I know we'll get to a little bit later on.
Definitely. I mean, so just to go off what you mentioned there, is that one thing I've heard a lot from people like who come to our groups or just people that I know is that people might often almost be fobbed off for saying, oh, it's just mild arthritis. Because when they look at an X-ray or something oh, there's not much there, so you're fine. So you're saying that's kind of not necessarily the case. So someone can actually feel a lot more than an X-ray would show.
Definitely. Yeah. So there's a discord in both directions. So some people will have really end-stage radiographic disease and little, if any, cartilage or joint space left on an X-ray. But by the same token, with that X-ray, have little or no symptoms and feel no loss of function. But the contrast is also true. So, some people will have minimal changes on an X-ray or an MRI, but have quite marked symptoms related to that. And we're starting to get a better handle on why that discord may be true. And so in part, it's because of, I guess, a better understanding of why people get pain and osteoarthritis. And so we use this biopsychosocial model. And so the bio relates to the biology. So that's the tissue change that occurs at the level of the joint. The psycho relates to the concomitant presence of things like depression, stress, anxiety, which are very common amongst people that have osteoarthritis. And the social refers to typically the social determinants and the socioeconomic status. And so the psychosocial, which we can't see obviously on an X-ray, is incredibly important in how pain it gets expressed and how disability occurs for people that have arthritis. Hence, I think that contributes quite markedly to that disagreement or discord between what we see on X-rays and what a person feels.
Also, to elaborate on that, are there any like subcategories of osteoarthritis? Like, are there like different like offshoots of it? Because I know, like, I mean, arthritis itself is essentially an umbrella condition, isn't it? So, are there further like down the rabbit hole of different types of osteoarthritis?
Yeah, very much so. So, as you said, Mark, it is an umbrella disease. So, like heart disease has lots of different types within that, or dementia has lots of different types of dementia. Osteoarthritis similarly is what we call an umbrella disorder. And so there's lots of subtypes or what we might call phenotypes of osteoarthritis. The most common ones are metabolic, post-injury, post-menopause, inflammatory. And then there are some less common ones that oftentimes relate to family history or occupation. But the most common ones that we see these days are the subtype related to either post-injury, which is usually following a sports injury where you injure your cruciate ligament or your meniscus and you subsequently develop osteoarthritis as a consequence of that, and or alternatively the metabolic syndrome, which probably accounts for about 40% of the people that have osteoarthritis. And so that's the metabolic syndrome is increased waist hip circumference, obesity, concomitant presence of high blood pressure, diabetes, which creates a systemic inflammatory state that predisposes people both to increased load through their joint by virtue of the weight that they carry, but also systemic inflammation can also lead to the development and acceleration of osteoarthritis itself.
Okay. So what are the primary symptoms of osteoarthritis as a whole then? Like like how you mentioned X-rays already, but how is it diagnosed in a person?
The typical presenting symptom is pain, and usually that's pain related to a particular activity. And so, for example, a person that might have hand osteoarthritis, it's pain related to oftentimes gripping or pinching something. So turning a door handle or opening a jar. For a person that has knee osteoarthritis, it might be pain on walking or pain going up and down stairs or pain on squatting or kneeling to the ground. And likewise, for people that have hip osteoarthritis, it might be pain getting in and out of a car, trying to put shoes and socks on. But again, the most common symptom relates to a pain with activity. And sometimes people also complain of stiffness associated with the disease, but usually that stiffness is very short and self-limited, oftentimes in the order of 30 to 60 seconds. And obviously, as a consequence of the disease, a loss of function. And so when we talk about measuring the disease, we talk usually in terms of measuring pain, measuring function, and looking at the impact this has on a person's quality of life and their ability to do activities of daily living and participate socially.
Okay, so what point do you think people should go to see their doctor about it? Like, is there like any specific signs other than just being in pain? Because I mean, people are in pain much more often than I think a lot of people realize. Where some people just put up with it and just get on with it forever. But at what point do you think is where they should, just go and see a doctor and get themselves checked out?
Ideally, depending upon your healthcare system, and so I'll qualify what I mean by that in a moment, the sooner the better. So the sooner we can intervene here meaningfully, the better for this person longer term. And so oftentimes when a person's first developing osteoarthritis, those symptoms might be intermittent. And so you might have a brief episode where your symptoms are present for sort of 3 to 7 days and then completely goes away. And over time, those episodes become more frequent and oftentimes become confluent. But typically in the first instance, it's very episodic and a person's well between times. And the rationale for recommending that a person go along sooner rather than later is the leading risk factors for the disease and its progression are modifiable. And so if you have osteoarthritis or you are developing osteoarthritis and a doctor or a physiotherapist or another health professional is able to identify that there are certain factors that you have, for example, you're carrying excess weight, your muscles are not particularly strong, you're sedentary, if those factors are present, then they're modifiable. And ideally, the sooner we do that, the better for that person's long-term prognosis and the trajectory of their disease.
Okay, so I mean, to go back again to something you mentioned in like the previous answer and in this one as well, like people will feel like, say, pain with activity. But as I think we mentioned, everyone's probably bored of me talking about this on this podcast, but I'm not going to stop. Things like how important physical activity can be for the treatment of osteoarthritis as well. How do people balance that? It's because it is a balancing act to figure like, so you're in pain. So how do you like, then kind of treat yourself? Well,
yeah. So oftentimes the activities we're talking about are undertaken by a person who doesn't either have optimal strength or alignment of the joint that they're using for that particular activity. And so, for example, a lot of people complain about pain going up and down stairs, and that often relates to a joint at the front of the knee between the kneecap and the thigh bone, what we call the patellofemoral joint. And more often than not, when a person's either going up or downstairs, the knee goes in underneath them rather than staying neutral or directly above their toe. Or they may have too much forward trunk lean. So essentially their upper body leans too far forward and places too much weight down in over their knee. And so the activity itself can produce symptoms, but we wouldn't generally discourage a person from participating in that activity, just learn how to do that properly. And so the contrast here between the activity producing pain and the therapy of what we would generally encourage a person to do with osteoarthritis is to promote their physical activity, is we focus very much, at least in the first instance, on activities which we know are likely to be well tolerated. So oftentimes these are low impact activities. So they might be things like Tai Chi, yoga, hydrotherapy, riding a bike, swimming, kayaking, things of that nature, primarily because they're not putting a lot of high impact load through the joint, and most people should be able to tolerate that pretty well. But we often also do that in concert with muscle strengthening, primarily because we want to optimize the loading conditions across the joint and improve the muscle strength in and around the joint that's primarily affected. So we know that physical activity is helpful for a person's symptoms. It's helpful for the disease long term. And so we generally encourage people to be active rather than not. And so historically, unfortunately, a lot of people had pain with activity, and oftentimes they went along and saw their helpful healthcare professional who said, well, you've got pain. You probably need to sit on the couch a little bit more and do less activity. And that was pretty much the wrong thing for them to be doing, because we know long term, if the person does the right activity and they're looking after themselves well, their prognosis, the joint pain will be a lot better longer term.
It's always shocking to think that like it wasn't necessarily that long ago that things like, oh, just bed rest, just rest everything was like the answer, when it's just now we're just so on the other side of that.
Yeah, for a lot of different reasons. But, obviously for your general health, there's no benefit really to being excessively sedentary. And similarly for your joint health. I mean, the joint itself, I mentioned at the outset that every joint has the capacity for repair. The more you stimulate that with activity, the better the reparative conditions typically are. So your joint's ability to repair, or what we call be trophic, is stimulated by you being active. And so the less active you are, whether that be on a couch or through space travel, for example, the less load you put through the joint, the less stimulus the joint gets for repair and its overall health.
Okay. So I guess a lot of this comes down to some things like lifestyle factors and just like, general activity? Are there any other ones that you think are important to mention? I know you've mentioned obesity already as well as a really important one with osteo, but anything else you think would be useful for people to know about?
Yeah, Mark. I mean, I think it's incredibly important to emphasize what we call are the core treatments. And so they are four. The first one, and a really important one, is just education. So just knowing what the disease is and what you can do about managing this yourself. Because the more you arm yourself, the more empowered you are to look after it longer term. And there's a lot you can do. So education is first. We would then start talking about therapeutic exercise or strength-based exercise. And typically that's focused on strengthening the muscles in and around the joint. I mean, so there's a huge number of ways that can be done. Ideally, we recommend that be done in alignment with a health professional, such as a physiotherapist or an exercise physiologist, teaching you how to do this carefully with appropriate technique and encouraging you to build up strength over time. The third, and one that we've already emphasized, is that of physical activity, and generally encouraging you to meet sort of the heart guidelines around activity levels. For a lot of people who have osteoarthritis, they've been sedentary for a long while. And so going from being sedentary to what we would consider of satisfactory levels of physical activity of about 150 minutes per week of moderate, vigorous physical activity sometimes takes a while to get there, but that's essentially the target in terms of physical activity. And then the fourth is optimizing your weight. So if you're above a healthy weight, trying to get your weight down into a healthy weight range, because we know that if you carry excess weight, you lose, for example, 7.5 to 10% of your body weight. Your symptoms will be cut in half just through a combination of diet and exercise and reducing your body weight. So those four things are key. I'm not suggesting by any stretch of the imagination that those things are easy to undertake, and sometimes changing behaviors which have been present and ingrained for years or decades takes a while to change. And so it's really important, that in general, they're very helpful. You try not to do this alone. So get help from a healthcare professional to empower you along the way and help shepherd you through this journey. But in general, people who follow those simple behavioral remedies do incredibly well.
I think, yeah, you've really touched on it. So one of the important things is long-term sustainable changes to your lifestyle rather than quick fixes. Like just doing your physio exercises for a couple of months doesn't make it go away. You have to change something essentially for the rest of your life because you're in it for the rest of your life.
Yeah, for sure. I mean, for a great way to exemplify that is oftentimes from a muscle strengthening standpoint, for us to see meaningful changes in strength and function of a muscle will take 3 to 6 months of solid training. Likewise, for us to see meaningful changes in weight, we're not really interested in you doing something that leads to massive weight loss over a course of weeks. We're interested in you doing something that is sustainable and meaningful longer term. And again, that often takes in the order of 6 to 12 months. And obviously, we focus very much in the programs that we run for people that have osteoarthritis on commencing a person on that journey. And when I say commencing, our programs usually run for 6 to 12 months, but it's critical that we also focus on its maintenance. And so, this is a disease that has a duration typically for most people of about 25 years. And so for that part, if we intervene and our intervention lasts for 12 months and then we tell a person to go off and hopefully have the skills to manage this longer term, we hope that they will then be able to sustain this longer term. And we've got good data to suggest out to sort of 3 to 5 years that people can sustain these changes and get meaningful benefits for their symptoms by changing behavior.
Cool. So after that 3 to 5 years, is there just that there isn't the data for it, or do people then kind of like start to decline again through maybe giving it up?
No, we really just don't have the data.
Okay,
yeah.
good. I was worried then just to find out people just tend to give. There's a stat that people give up after 5 years. That'd be terrible.
No, that old adage of never give up here is really, really important. So, I would imagine the trajectory of this illness is one where if you meaningfully change your behavior, the trajectory would be favorable long term.
Okay, excellent. Good to hear. Good to hear. So, a couple of little sort of random questions, I suppose, really. One that I get asked a lot, and would love your take on it, is osteoarthritis hereditary?
It's a great question, and one that similarly I get asked quite a bit as well. And so it depends. And so for hand and hip osteoarthritis, about 50% of a person's likelihood of developing that relates to genes. And so essentially, oftentimes, this is maternally inherited and genes that are passed down from a person's mother. So that's hand and hip osteoarthritis is a very large genetic contribution. For knee osteoarthritis, most of the larger studies would suggest it's probably more like 20 to 25% of a person's likelihood of developing knee osteoarthritis relates to their genes, or what we call the heritability. There are some very rare genetic changes that can contribute to the early onset of osteoarthritis. And so people who are of short stature, who traditionally, I guess, historically were called dwarfs, typically have a condition called achondroplasia, which is primarily a problem with the growth plate, so the cartilage plate within the joint. And so they get early development of osteoarthritis in multiple joints throughout their body. And so there are, as I say, very rare instances of early onset osteoarthritis. But for the most part, for knee osteoarthritis, there's a small contribution from heritability or family history, but for knee and hand osteoarthritis, there's a much greater contribution.
Okay. Yeah, going back to that then, or expanding on that then, osteoarthritis is often something that's thought of like, that you get in your older age. As like statistically, it is often than not, the older you are, the more likely you are to have it. If you could explain why it's more common in older people. I know it's a fairly tricky one to answer in a way, but if you could, that would be great.
Yeah, I mean, so I guess just to put one myth to bed, because I think a lot of people believe this is just a disease of older adults, but the average age of the person that develops osteoarthritis is now about 55, and about 2/3 of the people that are affected by osteoarthritis are of working age, so they're under 65. And so it's not just older adults that are affected by this disease. Why do people get osteoarthritis as they mature? Primarily because of the joint's capacity for repair declines. And so our own joints repair processes are slow over time. In addition to that, our muscles become weaker. Oftentimes, we're less active than we were before, and sometimes the muscle itself is replaced by fat. So the quality of the muscle itself is less than it was when we were younger. And all of those mechanical changes that occur there as a consequence of loss of strength, loss of the joint's capacity for repair, begin to build up over time. Now, I don't want people to believe, as a consequence of what I just said, that osteoarthritis is inevitable, because I know plenty of people over the age of 90 or 100 that don't have osteoarthritis. So it's not an inevitable part of the aging process. It definitely is more common as we age, but it's not inevitable. And again, just to stress, it's not just older people that get osteoarthritis. There's a hell of a lot of young people get osteoarthritis as well.
That was going to be my next question: is how common is it in a younger age range? I know that's a very broad and vague term, a younger age range, but let's say below 40.
Yeah. So let's say that about 12.5% of the population over 40 will have pain and radiographic changes consistent with osteoarthritis. So below the age of 40, it's much less common. But over the age of 40, it's about 12.5%. It's much more common in people after the age of menopause in particular. But under the age of 40, it's less frequent than that. And when we do see it under the age of 40, there are a couple of different things that make us think, okay, so this is probably a person who's injured their joint when they were very young, or they've carried excess weight through their young adult years, or they've got a family history that's predisposed them to this. And, in general, for at least two of those factors, particularly the joint injury and body weight, there are things there that we can modify, things that we can change to help that person's long-term prognosis. It's not to say we can't help a person that has a family history of osteoarthritis, but I guess the key messages I generally give to a young person who may be either at risk or has early symptoms is just focusing back to those core treatments. So stay strong, stay active, and maintain a good, healthy weight. They would be the three key messages that I give. There's a lot of other things that people throw at people that are at risk of osteoarthritis, in particular talking about exclusion things from the diet or going on different supplements that are purported to modify a person's risk of developing osteoarthritis long term. But we really don't have good evidence for that. So we do have good evidence that staying active, keeping your body weight down, and being strong does have an influence on a person's likelihood of developing osteoarthritis and its progression.
Yeah, I think prevention is something that people are always sort of keen to do. I mean, is there a way to prevent osteoarthritis?
Yeah. So again, if we singularly focus down a little bit on knee osteoarthritis, and apologies to people who have hip and hand osteoarthritis or osteoarthritis somewhere else, but the analogy probably crosses a little bit. The two leading risk factors for the development of knee osteoarthritis, about 50% of a person's likelihood of developing knee osteoarthritis relates to body weight, about 20% relates to joint injury, both of which are modifiable. So let's just talk through each of those. So from a body weight perspective, for every additional kilogram that you carry, there's 4 kilograms of load goes across your knee. In addition, there's those systemic inflammatory factors that we spoke about before. We're actually in the process of undertaking a prevention study at the moment, targeting women over the age of 50 carrying excess weight and treating them with a combination of diet and exercise over the course of 4 years. And our modeling would suggest that we will reduce the number of people who develop osteoarthritis by about 25% by keeping their body weight down. So we're confident that we can do that. There's good data from epidemiologic studies suggesting that that will be the case. And so for the general community, we generally encourage them to keep their weight down if they're at risk of developing osteoarthritis. And the second relates to joint injury. And so oftentimes this is incredibly troubling, primarily because what we're talking about here is people oftentimes between the ages of 15 and 25 who are incredibly active, playing sport, really quite vital people who tear their cruciate ligament or the meniscus in the knee playing sport. Now, more often than not, these are non-contact injuries. So the majority of them, it's not by virtue of someone hitting them in the knee. It's by virtue of the way they land on their knee. And so there are wonderful training programs that are developed by the Football Federation, so FIFA. There's a PEP program. There's a number of different sports that have these training programs to prevent joint injury. And very forward-thinking countries around the world, and I'm not including Australia on that list at the moment, have these prevention programs that have been rolled out nationally, and they reduce their injury rates by about 60 to 70%. Now, ideally, we would do that throughout the world. Unfortunately, we don't. And the consequence of that is there are increasing numbers of people injuring their joints by virtue of increased participation. And I'm not discouraging people to be participating in sport. We should just ideally do that safely. A lot of people believe that, okay, well, I've torn my cruciate ligament, I can just get it repaired, and that, there's no risk for me developing osteoarthritis long term. Well, I just want to let you know that reconstructing your cruciate ligament doesn't change your long-term risk of developing osteoarthritis. About 70% of people who tear their cruciate ligament will develop osteoarthritis within 10 to 15 years. So these are people in their 30s and 40s developing knee osteoarthritis, and it has a massive impact not only on their sports participation, but on their quality of life subsequent to that injury. So it's incredibly important we try to think a whole lot more about preventing these injuries from occurring in the first place.
Wow. Do you think that, I mean, this is something I have heard as well. I'd love to get your take on it. Like, have you seen a change in like the ages, as you mentioned earlier, like the average age is like, say, 55. Are younger people getting getting arthritis more often these days? Is that something that's changed?
Definitely. And so there's a wonderful study done by colleagues in the US. It was published about 5 years ago that looked at the average age of diagnosis of osteoarthritis in the 1990s. And the average age in the 1990s for the diagnosis of osteoarthritis was about 66 years of age. They looked at data from a closer period of time in the 2010s. And the average age then was 55. So it dropped basically in the order of about 11 years in a 20-year period. And so what's happened in that 20-year period that's led to much earlier onset of osteoarthritis? There's probably two main things. One is increasing weight in the community. And so we know that body weights are going up throughout the world through a combination of both increased caloric intake and reduced activity. But the other really big factor here is increasing numbers of joint injuries, particularly amongst young women, where there appears to be an epidemic of joint injuries occurring in young women playing competitive sport. And I'm just want to stress, I'm not discouraging people being active and participating in sport. I just really want them to do so safely and do these injury prevention programs as part of their participation.
That's really interesting to hear as well. I mean, I'm sure lots of people have heard this before, but like, it's quite often osteoarthritis is, statistically more common in women, I believe. Is there a reason for that?
Yeah, it's probably 2 times more common in women than it is in men. And more often than not, that gender disparity, that's predisposition to women being affected, appears to become present after the age of menopause. So under the age of 50, osteoarthritis is probably equally common in men and women. But after the age of 50, it's more common in women than it is in men. I mean, there's probably a few different factors that contribute to that. So one is likely to be changes in hormonal balance. We just haven't quite worked out what changes in hormonal balance are important. In addition, because of what we call neuromuscular or biomechanical factors. So if you have weaker muscles, you are more likely to develop osteoarthritis. And so, and by the same token, if your body composition has less lean mass and more fat mass, and again, women have that by virtue of just their biology, that does place them at greater risk. And then in addition, the alignment of the lower extremity puts some parts of the knee at greater risk of developing osteoarthritis. And so by virtue of having a slightly wider pelvis, by virtue of they will have changes in the alignment of the knee, what we call the Q angle, which again can increase a person's predisposition to osteoarthritis. So osteoarthritis is more common in women. There are a range of different factors that likely contribute to it, some of which are modifiable. And there are a lot of people working on trying to fix that at the moment.
As we've mentioned several times now about modifiable sort of factors, what about things that aren't? I mean, what kind of treatments are available for things that can't necessarily be modified, like things that can't be taken care of by, say, exercise or, diet or weight?
So sure. So, but I mean, I think obviously two of the factors we've spoken about already. So age and genetics are two of the things which at present we don't necessarily have direct targeted therapies for. People are working on genetic therapies. They're also working on this whole area of anti-aging or anti-senescent therapies. But we don't have any available that are approved by the regulators at the moment for that purpose. Irrespective, if you've got osteoarthritis, those core treatments we spoke about before in terms of staying strong, staying active, keeping your weight down are incredibly important irrespective of how you've developed osteoarthritis. And so the messages run true irrespective of how you've developed osteoarthritis. The beauty of having a modifiable factor is that way you can emphasize that modifiable factor a little bit more as far as that treatment is concerned. So, we know that if a person's got particularly weak muscles or a lot of excess weight, a lot of our effort in treating that person will go towards that particular part of that person's modifiable changes.
Yeah. Is there any medication that's used for osteoarthritis?
Yeah, so the first line analgesic, so pain reliever for osteoarthritis, is the anti-inflammatory group of medications, which can be taken either orally or applied topically. And so there are things like Voltaren, Brufen, Feldene, celecoxib, a whole lot of different ones. And the usual advice for those is to take them in the smallest dose for the shortest duration possible. Primarily because whilst they're effective at relieving pain, they also carry with them a range of different toxicities, and particularly in the population of people we're talking about here, they often have other illnesses that travel alongside their osteoarthritis that anti-inflammatories theoretically can make worse, such as high blood pressure or previously having a stomach ulcer. And so in that particular context, we need to modify how and what type of anti-inflammatory we might use. But that's typically the first line analgesic we use. Sometimes we also inject corticosteroids into a person's joint. But again, we wouldn't typically do that repeatedly because it does carry with it a risk of accelerating the progression of the disease.
How do you think osteoarthritis impacts younger people, working age people? How do you think it affects their work life or their sort of continuing life going on?
Yeah, it's an incredibly important question, Mark, primarily because I think oftentimes it's underestimated the impact that this has. And so As mentioned before, osteoarthritis oftentimes presents with a person complaining of pain associated with activity. And so for a person that's doing a manual or very physically demanding job, and they've got knee or hip osteoarthritis that's causing them pain, oftentimes that will lead to limitations in their workplace. Now, more often than not, what we try to do is find a way to improve their osteoarthritis to a point where they can either A, tolerate that activity, or modify the activity so that it becomes more tolerable. I think just to put this in perspective, this is the leading cause of premature retirement from the workforce. And so oftentimes, I think that goes unnoticed, but that has a huge economic consequence, both for the person that's affected, but also for society as a whole. And so the challenge here is oftentimes these are people in their 40s, 50s who've developed osteoarthritis by virtue of injury or some other familial problem that are retiring early. They haven't earned as much. They don't have as much stacked away on superannuation. And a large proportion of these people, unfortunately, live below the poverty line, depending upon where you live around the world. And so, identifying these people early, intervening early, trying to accommodate for the changes that they might require in the workplace. And so we work very closely with a group of healthcare professionals called occupational therapists who help us very much in this regard, to help a person to find accommodations in the workplace so that they can continue to work for longer rather than to become unemployed.
Definitely. Also, especially like say in the UK, certainly occupational therapists can also visit people's homes and make sure that they even have that they're set up at home as well to make sure they got all of the adjustments and extra things that they can. Depending on the funding in your area, of course, there are limitations depending on where you are.
Yeah, no, it's an incredibly important role for the allied health for the people that have osteoarthritis. And as you say, whether that be in the workplace or at home, they can provide great contribution.
So last question then. So any advice, just anything like top factors you think for people who might have osteoarthritis?
Yeah, I think the key things that I'd really like to stress is to stay active and empower yourself. The more you know about this disease, the better. And the more active you remain in managing this disease, the better you'll be long term. For most people with osteoarthritis, this is a disease that has a long time course. But the prognosis, your journey with this disease, is generally favorable if you follow those simple remedies we were talking about before of staying strong, staying active, and maintaining a healthy weight. But to get better knowledge, obviously listen to Marc on Arthritis Action. We have a podcast called Joint Action to help get people who have osteoarthritis better informed about the disease. But really empower yourself with knowledge that will hopefully help you better in the longer run.
Amazing. Thank you so much. Thank you. And if anyone would like any more information, as you mentioned, like the information we have with things like, fact sheets, various exercises, loads of information on physical activity and other lifestyle factors that you can, make some positive changes in, please do go to our website, which is www.arthritisaction.org.uk. And if you have any questions, feel free to send us an email to the podcast, which is podcast@arthritisaction.org.uk. So amazing, David. Thank you so much for your time today. Really appreciate it.
Great pleasure to be here. Thanks for having me along, Marc.
And thank you, everyone, for listening. Cheers, everyone. Bye-bye.